My name is Jeremy Peterson. I'm a student physical therapist at Campbell University, and today I'm going to demonstrate joint glide mobilizations for the talocrural joint. For clarification of grading for joint mobilizations, I'll demonstrate the Maitland Joint Mobilization Grading Scale. Alright, so here we have a lovely diagram of the Maitland Joint Mobilization Grading Scale. This kind of gives an idea of the different grades you can use when you're employing the Maitland joint mobilization techniques. There's a grade 1, grade 2, grade 3, and grade 4. So to kind of explain what's going on in this depiction here, this first line here, labeled R1, is going to demonstrate the point of tissue resistance. So past that point, you're going to start experiencing some tissue stretch. This R2 represents the point of anatomic limit. This is the point where that soft tissue cannot stretch anymore, and if you go any past R2, you're going to actually have a rupture in that tissue. So this is the point of anatomic limit of the particular soft tissue. So for grade 1, we're looking at small amplitude oscillatory movements that are in the beginning of the joint range. For grade 2, we're looking at large amplitude movements that are further into the range, but not quite getting to the point of tissue resistance. So we're not quite getting to the point of stretching. These first two, the grade 1 and grade 2 joint mobilizations, are going to be used for patients with a pain-dominant limited range. So these first two grades are essentially for patients that are experiencing a lot of pain. It's more so for pain reduction, not so much for increasing joint mobility or trying to get increased range at that joint. So once you get past the point of tissue resistance, we're talking more about a grade 3 and grade 4 joint mobilization. So grade 3 is looking at your larger amplitude, kind of similar to grade 2 in that it's large amplitude, but it's actually going into tissue resistance. So at this point we have a large amplitude movement going into the tissue resistance, so we're trying to get increased range or increased mobility of that particular joint, of that particular soft tissue and surrounding joint structures. And grade 4 is also addressing or going into this point of tissue resistance. And grade 4 is kind of similar to grade 1 in that it's a small amplitude movement. It's kind of a quicker oscillatory type of movement. And it's also addressing or starting to go into this point of tissue resistance. So grade 3 and 4 are more so for patients that are stiffness dominant as opposed to pain dominant. So in this case, the idea or the goal is not trying to reduce pain. We're actually trying to increase joint mobility or trying to get that joint actually moving more. I'm going to demonstrate joint mobilization glides of the talocrural joint. I'm going to first show posterior joint mobilization, followed by anterior joint mobilization for this particular joint. When performing this mobilization, I want the joint placed as close as possible to the relaxed or loose packed position. In this case, for the talocrural joint, it's about 10 degrees plantar flexion. So just slightly into plantar flexion, a little past neutral. So in this case, I'll start out doing the posterior mobilization. I want my stabilizing hand as close to the joint line as possible, stabilizing the mortise, stabilizing the distal tibia and fibula. The mobilizing hand is over the dorsum of the foot, trying to get as close to that talus as possible, so kind of over the talar neck and top of the talus. So when doing the posterior mobilization, pushing straight down through the dorsum of the foot, trying to make that talus go posterior within the mortise, within the joint. And with this, I want to make sure I apply a slight distraction prior to the joint mobilization. So I'm going to do a slight distraction of the talocrural joint before I push down into that posterior mobilization. And with a posterior glide, as you get to the end range, there is a conjunct external rotation of the talus. So it's pushing slight distraction, pushing down, and then an end range, a slight external rotation of that talus. Doing okay? Mm-hmm. Good. So for grade 1 mobilization, it's going just into the beginning of their range. So small oscillatory motions just in that beginning of the range. For a grade 2, going a little bit further into the range, but not to the point of tissue resistance. So a little bit larger amplitude oscillations. And then grade 3 is going into that end range of tissue resistance. And at the end range here, make sure we have that conjunct external rotation of the talus. Good. And then for grade 4, it's just getting into that end range, and it's a small oscillatory motion just at that end range. Most of the studies on talocrural mobilizations have small sample sizes and thus limited statistical power. However, there is evidence for this technique significantly improving range of motion and the glide of the talus within the mortise. A study in the Journal of Manual and Manipulative Therapy in 2008 investigated the effectiveness of grade 3 anterior to posterior talocrural joint mobilizations after a period of immobilization, at least 14 days for subjects in the study. There were 10 subjects total. Half were in the group receiving AP joint mobilizations, and half were in the control group receiving no treatment. After a single application of grade 3 AP talocrural mobilization, dorsiflexion range of motion was significantly increased, and there was also a trend toward less posterior talar translation. A study in 2006 investigated the additive effect of combining posterior talocrural mobilization with active dorsiflexion movement. 16 subjects with a history of recurrent lateral ankle sprains and deficits in posterior talar glide and weight-bearing dorsiflexion were studied. The mobilization with active movement technique was done in weight-bearing and non-weight-bearing, and there was a control group that received no treatment. Both the weight-bearing and non-weight-bearing mobilization with movement were effective in improving posterior talar glide significantly greater than the control group. They also improved weight-bearing dorsiflexion more than that of the control group. These results suggest that this technique can be valuable for those with recurrent lateral ankle sprain.